Hey everybody, welcome to the Moderate TBI presentation. Our group consists of Shane Johnston, Corey Pelser, Morgan Parker McKinney, Ethan Burke, and Troy Sawyer. So our patient is Michelle, who is a 52-year-old woman. She's known in the community as GMA. She sustained a traumatic brain injury about 5 weeks ago, and she just arrived at the acute rehab facility from the acute inpatient hospital. Her mechanism of injury was a counter-coup injury during a motor vehicle accident. She was ventilator dependent for 11 days and she has been weaned off of that. And she requires moderate to maximal assist with all mobility skills. She is also easily agitated. So a moderate TBI is a loss of consciousness from 20 to 30 minutes, a Glasgow coma scale of 9 to 12, possible skull fracture with bruising or bleeding, and positive signs on imaging such as an MRI, with some long-term problems in one or more areas of life. Michelle's mechanism of injury was a counter-coup, which means that there is damage on both sides of the brain. At first, the front of the brain kind of hits the front of the skull, and then as the head is moving backwards and it's starting to decelerate, the back of the brain will then hit the back of the skull. So before we walk in to see Michelle, there's going to be some things that we're expecting with a moderate TBI. Some of these things are possible spasticity, associated movements or synergy issues, respiratory issues, general muscle weakness, maybe an impairment in cognitive ability, and coordination loss.
So the first article that we chose to examine to find interventions for our patient was published by Physiotherapy Theory and Practice. So just to give a brief overview of this article, it examined 22 patients. And they were given rehab therapy that focused on eye movements and eye-head coordination exercises in sitting and standing, multi-segmental coordination, sitting balance, movement precision, static and dynamic balance, gait initiation, and gait pattern. So this study included, like I said, 22 individuals, 9 were female, who had sustained a brain injury as a result of trauma about 8 to 47 months before therapy began. Participants were admitted into the program with TBI from local rehab centers. The eligibility criteria included a history of TBI sustained over 6 months previously with a stable clinical status, an ability to stand unsupported for at least 2 minutes, full or near full active ranges of motion in major body joints, normal or corrected to normal vision, related injury, mild to moderate coordination abnormalities involving upper and lower extremities, postural instability, and an ability to follow simple instructions. So to get a little more specific into the exercises that the study examined, they did a number of different positions, the first being exercise while laying on the mat. These were more focused at increasing that postural stability, increasing core strength, activities resembling bridges and supine, things of that nature. They also moved on to exercise while sitting on a chair with feet flat on the floor. These were generalized to increase postural sitting balance. They included exercises that worked on head and eye coordination, as well as postural stability exercises. They also worked with patients in standing with feet apart, which is where we try to implement some of our interventions, as well as exercises while walking. These were both done in parallel bars. So what did the results of this study show? The outcome of this study was really positive. Participants demonstrated improvement balance and in gait, reduced ataxic symptoms, and increased functional independence levels. So to run through what we took away from this article and to what we applied to Michelle's treatment, I'm just going to run through a bullet point section here, and then there's going to be a video shortly after where Morgan's going to illustrate this exercise. So within the parallel bars, the patient is going to step on the ground and step back to their initial position. The targets that they're going to be stepping towards are placed in front. lateral to ipsilateral stepping foot and behind the patient. The facilitation of the muscle is going to be needed to extend the step length and get heel strike first with forward and lateral movement. The physical therapist facilitation of the muscles is needed for hip extension with stepping backwards, and repetitions would be done to the patient's tolerance on this one. The goal of this intervention is to promote coordination with stepping, and it combines several smaller interventions from the Ustonova et al. Article.
All right, in this intervention here, what we're focusing on is posture and coordination with stepping. The therapist is helping the patient to maintain an upright posture, facilitating the glutes and the upper trunk. The other therapist is there for safety and for additional cueings in the upper trunk, while the therapist sitting in front of the patient is working on facilitating the lower extremity. Here, the therapist is cueing the patient on using the hamstring and tibialis anterior with stepping. As the patient heel strikes down, the therapist cues the quadriceps and glutes to extend to help the patient weight bear through the lower extremity. The next phase is going to be stepping back, facilitating the hamstrings, making sure that the patient is able to get that weight acceptance onto the right leg. Again, maintaining posture during the therapeutic exercise. Now, the next step is stepping off to the side. Stepping laterally is a skill that the patient's going to need to have. So we're going to work on stepping laterally, cueing the muscles to work and accept the weight, and then we're going to step back onto the other target. The patient is also being cued at this time to look back before stepping, which they did. And now the patient can step back to neutral. And this could be done in a pattern, stepping forward to the side, stepping back, or could be done with a random practice by just saying step to this color. So step to yellow, step to red, step to orange.
All right, our next intervention focused on pelvic PNF and core stability. The PNF patterns utilized were rhythmic initiation, slow reversals, and agonistic reversals. We got this protocol from Sharma et al. 2017, where they took two groups of hemiplegic chronic CVA patients and compared pelvic PNF and flexibility to core stability and pelvic PNF, and found superior results in mobility and coordination with pelvic PNF and core stability training. So, in summary, we will be using a combination of core stability training and pelvic PNF to increase Michelle's coordination and independence with movement and reduce her trunk and pelvic dysfunction.
Okay, so here we'll be demonstrating some PNF exercises from the Sharma article, and we're starting with rhythmic initiation. So I'm now passively moving Michelle's pelvis into anterior elevation and posterior depression. Then I'm going to cue Michelle to have her do it herself with some manual and tactile cueing. So I would have her bring her pelvis up towards her belly button and back towards me. And then the last part of the rhythmic initiation will be the dynamic reversals, where I'll provide some resistance with quick stretches here. And for the next exercise, Michelle will be in supine position and performing bridging exercises. And we will be performing agonist reversals, where I will perform right here resistance for concentric contraction, and then have her not let me push her down for an eccentric contraction.
All right, our mindfulness article was looking at 76 participants who had brain injury, and it took place over a 10-week period. The interventions that were looked at during this were breathing exercises, gentle yoga, acceptance, and staying present. The duration of the intervention was 1.5 hours per week, and daily meditation at home for 20 to 30 minutes for the 10-week duration. The treatment group got the 1 hour and a half of education mindful practice, and ended up increasing their or reduction in their Beck Depression Inventory T-score by 6.63 over the 10-week period. The control group had a decrease of 2.13. The power for this was 97.1%, and the effect size was 5.6, which is a strong power and a medium effect. This relates to our patient because breathing techniques, self-awareness, remaining present are things that we can do to help deal with depression and are going to increase the quality of life for our patient. It's also going to help with the overall prognosis and preparing the patient for activities like PNF and coordination.
So our next exercises will be breathing exercise and mindful practice and meditation. What we're doing right now is instructing Troy on diaphragmatic breathing and the benefits to him. And essentially we are stimulating the parasympathetic nervous system and helping Troy to relax and lower anxiety currently. The cues we are giving right now are, as you breathe in, try to breathe into your belly and make my hand raise. Now we are doing a guided meditation to help Troy be present in his body. So we are simply talking him through a process of bringing awareness to his head, neck, shoulders, arms, down his trunk and into his legs, and then bringing him back up. And you can see he smiles when he comes back, so he has lowered his depression and anxiety. The last technique we're utilizing is Troy's home exercise program, which is a personal meditation where he will be simply focusing on his own breath, counting out sets of 10 repetitions, identifying thoughts, and letting them go as they come to him without judgment and returning to his breath. And essentially he'll be doing this for 20 to 30 minutes a day as part of his program to reduce depression and anxiety.